for hyperthyroidism, you can follow down, you're going to check your TSH, and then you're going to go and check and see if it's low or high. Follow this down. If it's high, you're suspecting it being hypothyroidism because your stimulating hormone is high. And if it's low, then it's not stimulating very much because it's going too fast already. It's already hyperthyroid. If it's hyperthyroid, you're going to go and measure the T3. I like to measure the free T3, but you could measure either as long as you're familiar with what you're looking at, and then you can confirm this. Unfortunately, this is not as easy as this. And then if it's high, you can suspect hypothyroidism, and that can be confirmed with measuring your free T4. And if your free T4 is low, then you can confirm that it's hypothyroidism. And then you have your normal range. Unfortunately, people don't fall into this beautiful algorithm as easily as it looks here, but we'll get into that. Oops. Okay, so again, this is just another kind of chart that can show you kind of if your TSH is high, if your TSH is normal, if your TSH is low, this is what you can expect. If your TSH is high, you're going to think about a TSH secreting tumor. You're going to check the free T4, even though if your TSH might be a high to a normal level. If it's normal, it's euthyroid or normal with with T4 antibodies. That's very uncommon. I've never seen it, but it can happen. And then you could have thyroid hormone resistance. Again, not something I've ever seen or treated necessarily, but I feel like at some point with some of this stuff, I tend to refer out because I don't feel comfortable. Some of the medications work directly, and I'm not a fan of putting my patients at that much risk. I don't feel comfortable with that. And then if it's low, then you have hyperthyroidism, and then you're going to look for potential, and then you have low and then a normal plasma T4. You're going to have likely T3 thyrotoxicosis, and that could be early in the treatment of hyperthyroidism or in subclinical hyperthyroidism. Does anybody know what subclinical refers to?
Well, TSH is high, but the T3 and T4 are normal.
Yes, and so in this case, the TSH would be low because it's subclinical hyperthyroidism. But yes, it's much more commonly referred to when somebody has subclinical hypothyroidism, and it's seen much more frequently as well. And then normal, you have a normal thyroid. And then you could have a high TSH with a kind of borderline T4, and that might be compensated or kind of borderline. Look at your numbers, but look at your patient and see how they're doing. I'm sure with Dr. Wheeler, you guys will talk at some point about how sometimes when someone has difficult to treat depression, or alternatively kind of mild depression, that sometimes treating their thyroid, a TSH, an abnormal TSH, might be helpful, or if it's on the high side of normal, it can be helpful in addressing their symptoms. All right, and if you have a high TSH and a low T4, you have hypothyroidism, and that's kind of our typical what we see. If it's a normal TSH, but there's a low T4, is what you call sick euthyroid. So there's something going on. It could be potentially hypopituitarism, and should be looked into more in depth. And then if you have the low TSH, but you have a low T4, again, there's something going on. And look at your T3 as well. You want to look at that more in depth. Okay, so I just kind of put your symptoms all in here together. The first thing on there is hyper, the second is hypo. So I feel like I always think of, I don't know if anybody had that book I had in nursing school. I had some like it was kind of a mnemonics book and a book of, had pictures to help you remember things, excuse me. And so, you know, when somebody is like they're hyper, they're like, they're hot, their heart is racing. Either of them can cause an arrhythmia. They could be hot and sweaty. They might be losing weight because their metabolism is going so fast. They might appear anxious, might have oily skin or oily hair. Coarse hair as well, you might see. Either of these could cause a change in menstrual cycle, although more frequently I feel like I see hypothyroidism causing absence of a menstrual cycle, although hyperthyroidism isn't as common as hypothyroidism. With the GI system, with hyper, you could have the nausea, vomiting, diarrhea, whereas with hypo, everything's slow, so you get constipation. Even though in hyperthyroidism, you get insomnia, both with hypo and hyper, people feel tired. A tremor might occur with hyperthyroidism. Either of them could potentially have a goiter or a thyroid mass, or thyroid lump, thyroid nodule. And then only with hyper do you get ophthalmopathy. Bulging eyes. Sorry. Anyway, so, and then you're going to have the opposite of that when you're having hypothyroidism, maybe some bradycardia, a little bit of edema. You could still have that arrhythmia. You could have people feel cold. They've been gaining weight. They feel depressed. They feel unmotivated. They might be complaining of hair loss. That maybe is one of the more frequent things people come in for, though it's not always, maybe rarely related to hypothyroidism. We talked about the menstrual cycle. All right, so I'm going to keep going here. So we're going to talk about hyper first. It is not on all my slides. I just separated it into hyper first, then hypo. And so if you need to label them more, please do. So we already talked about this, your palpitations, your ophthalmic changes, eye changes, cardiovascular changes. So I want to stop for a minute. Why do you think that this is bad? If somebody is not terribly symptomatic, why do you think this is bad?
By this, do you mean?
Because it can develop into something worse if it keeps going on and on, right? Like it's not being treated at all.
It's being overworked. Like at some point, it'll stop working, or there'll be like a worse problem.
Right. So people sometimes will say, like, I think it's my thyroid. I think I need more thyroid medication, even though their T4 is normal and their TSH is normal when they're on thyroid medication. Why would you not want to give them more thyroid medication?
You could easily put them into hyperthyroid.
And so what is the risk of, if you have like just a little bit of hyperthyroidism long term, what risk is there?
Their cardiovascular risk, or
yes. Yes. And so you're really putting them at high risk for heart disease. And it's something that you don't want to, and arrhythmias. So it's really something that you don't want to mess with, but people will ask, they often want more medication. They're clearly gaining weight because of their thyroid or something. And so they want just a little bit more. And it is not safe because long term, this can cause some serious cardiovascular repercussions, particularly the ophthalmic repercussions. The bulging eyes is not really the issue. It's what happens in the back of the eye. So if there's increased pressure in the back of the eye, it can cause blurred vision. It can cause retinal detachment. I interestingly had a woman very recently who had, she had a normal TSH. She had a normal T3, T4. She had, we'll get into the TSI and the TPO. That was normal. And she had, they called it ophthalmologic hyperthyroidism. Even though her thyroid was normal, that was the cause. Like we did MRI and made sure there was no other cause for it. So she'll need to be monitored for that, but she could potentially lose her vision because of that change. And so quite pertinent that we don't want to be putting people at risk for that. Here's your values. I always, as I said to you, I like to go by whatever the lab has. And I like to check more of a free T3 and T4. Personal preference, I guess. I find it more helpful. That was weird. Okay. All right, so Graves' disease, this is the most common reason this occurs. It's an autoimmune disease. People might have what's called a toxic goiter. It could be multinodular or just nodular, an adenoma. Those are benign things. Even though it is benign, the nodules can create increased excretion of the T3. And with increased excretion of T3, you can still have hyperthyroidism, even though it's not a serious or a malignant issue. When they do they'll do the radioiodine uptake scan. When they'll say like there's a hot nodule or there's a cold nodule, those hot nodules are always benign. The cold nodules are about 20% malignant. Moving on, thyroiditis is, does anybody know what thyroiditis is?
Inflammation of the thyroid.
Beautiful, exactly. And with inflammation in the thyroid, it stops functioning correctly. And so it could be high or low, but it certainly, with inflammation in the thyroid, it's a temporary issue. It could be because of some kind of trauma or that happened with the thyroid. It could be a viral syndrome. I think there's plenty of unknown etiologies of why that occurs, but it's a temporary thing. And so when you're getting a TSH and it's abnormal, typically you're going to want to recheck in a little bit to see if it was a fluke, maybe thyroiditis, maybe a lab error, who knows, but see if that really is the case and it is consistently high. Now, if you have a TSH of 60, this is not thyroiditis most likely, or if you have since we're talking about hyperthyroidism, if you have a TSH of 0.2, that is not well, I guess that may or may not be thyroiditis. But you should be able to check in 4 to 6 weeks and it should be changed back. There's also radiation thyroiditis for people who got radiation for either their thyroid or other reasons that can also cause a temporary increase in the excretion of thyroid hormone. Sorry. I don't know how I'm feeling about this. It only works sometimes. My goodness. Previous. Oh, I guess it only did go. Anyway, so you could also have a secondary cause, the thyrotropin secreting pituitary hormone or adenoma, which is, so that's not in the thyroid. So it's a secondary cause. It's up in the brain and the pituitary gland. Okay. So there are some reasons that there's other reasons for hyperthyroidism. Here is a long, beautiful list of a lot of medications that can potentially cause problems. So when you're looking at these things, think about with excess levothyroxine, did somebody want to take more because they didn't feel like it was going right? Just like they want to take more of their blood pressure medicine if they had a high blood pressure that day or whatever. Sometimes people will just take more. Was there a change in something in their, did they used to take it with meals and stop taking it with meals? And so it's being better absorbed. And so there's an excess of the levothyroxine. And then there are over-the-counter thyroid supplements, and so they could be taken over-the-counter thyroid supplement as well. Here's our medications that can cause increased thyroid TSH secretion. Be aware of them. Metoclopramide, I feel like, amiodarone and metoclopramide, I feel like we see a fair amount. I don't know. I have a lot of patients on ADHD medicine these days. And Anyway, so this is ingestion. This can it can cause secretion. This can make a TSH secretion, which will then increase the TSH or T3 and T4. But the amiodarone and iodine ingestion, excess iodine ingestion, can actually cause more synthesis of the T4 and T3. And then these medications down here are going to show you they're going to have more free T3 and T4 because it causes a decrease in I said before that the thyroid hormone binds onto the protein. And so if it's not binding onto the protein, then it's going to be free floating in the body. And again, some of these are common medications. So things to kind of keep an eye on. All right, so presentation. Leanne, have you ever seen, sorry, your name is popping up on me. Have you ever seen a patient with hyperthyroidism?
Aren't they the skinny ones?
Yeah, have you ever seen one? No.
Yeah, I have.
Okay, then they were skinny, is that right?
Yeah, yes.
What else did you notice?
Were they the ones with the eyes? The big bulgy eyes? Yeah.
Yes.
They kind of bug out a little bit.
Yes, absolutely. Did you notice anything else weird?
I don't know. I feel like they stare a lot. No, I don't know.
Okay. Anybody else
wish
ever
I
seen
was-
somebody with hyperthyroidism?
My cousin was diagnosed with hyperthyroidism when she was 18. The main thing was she'd lost about a bunch of weight, and then she was very like emotionally erratic. So it was almost like combination of like trying to rule out why she was losing weight, and then the other thing is like why she was like it was almost like a psych workup also. And then they found that she was almost at a thyroid storm, so she was hospitalized immediately. And anyway, but yeah, we found it out more the psychological side of it.
Yeah, so so actually it's very appropriate that you said your cousin,
Yes.
that she was 18, because that is a time that it tends to appear, and in younger women. I had a teenager, I think she was 15-ish, 16-ish, and her mom was telling me how she had started acting weird and she was erratic and she just didn't seem like herself, and her mom really wanted me to do a drug test, and I was like, I don't do drug tests on request. But then she described her behavior to me, and I was like, I'm going to do a drug test, because it really was. It was really odd behavior, and she had a little bit of the bulging eyes, but I didn't know her, so I wasn't sure if that's really what it was. And she also looked like she was high on meth, right? Like she was kind of moving all around, couldn't sit still, and my computer's doing things by itself. And it was because she had hyperthyroidism. And so it was really interesting that, like you said, that was like a psych workup. Mine was like, I thought I was doing it was a psych versus I really thought it was substance abuse, just based on mom's description and the patient's presentation. So be aware of those things. Yeah, go ahead, Leanne.
I've also had one where they thought they were like having a heart attack. And then it turned out that it was actually thyroid.
Yeah.
Mm-hmm.
Yeah. People will think they're having a heart attack. They'll think they're having an anxiety attack. They can feel their heart pounding at night when they go to bed. So we'll talk about differential diagnoses at the end, but you guys are definitely catching on to them as we are going. And people don't always tell you all of the things that you think. Like if it's someone who's more middle-aged than younger, who's going through or like in the midst of menopause, they might think that the heat intolerance is just menopause. If somebody who has anxiety, they might think that palpitations is just when they're having anxiety, little anxiety attack. And so something to be aware of, that when your patient is talking, keep it wide, keep it really broad when you're thinking about what it might be. And then the elderly are, although it's not as common, when they present, it looks like they're apathetic, like they're not engaged. Like when you see an old person who has fatigue and weight loss and AFib, what do you think?
Sometimes it's just an AFib and like a failure to thrive, kind of dehydration, like
Yeah.
a little bit of pre-sepsis, something going on, like. Yeah.
Yeah, or depression.
Hmm.
I mean, if you told me that somebody had fatigue and weight loss, I would say that they had depression. If you told me they had AFib or it was a new finding of AFib, I would think that was a coincidence. So again, keep your differential wide as to what this might be. All right, we want to do the TSH first. The T4 isn't going to help us in this situation. I don't think it's wrong to get a T4. I think I mentioned last week that when I order it, I get a TSH with a reflex T4 so that I can find out what it is if there is an abnormality. And then we'll talk about the workup in a little bit, but we want to use, oh, hold on, this is the right slide. So we're going to check that T3, excuse me, to confirm, because the T3 is what's active in the body. That's what binds to the proteins. You can look at the perioxidase, and that looks for antibodies against the thyroid hormone. So thyroid is a negative feedback loop. Okay, so when there's enough thyroid, it stops making it, and so it stops giving you the stimulation. So that's a negative feedback loop. So when your TPO is high, it disrupts the negative feedback loop and it becomes more positive, and so your body doesn't stop like it's supposed to. You look at the TSI to look for different antibodies. These and the TSI is more located in your eyes and your skin. So that's what's going to cause the exophthalmia. That's what's going to cause the thickening of the skin on the the pretibial area on the leg. Maybe it's going to be thick, maybe even shiny skin, because that's where those cells are, and that's where that's where it's going to impact the body, right? It's going to where it's going to go, and then I put this here because I feel like if part of the workup, if you find these abnormalities, you would like to make sure that there's not more going on, right? And so typically if I have a low TSH, I get a T3, a TSI, TPO, and I do an ultrasound to start with. If there's anything on the ultrasound, and I didn't put ultrasound on the last page, I'm sorry, I was going to put it and they ran out of space and then never went back and did it. So write down ultrasound, please. You're going to order those things. And then if they need a radioactive iodine uptake scan, then you're going to send them out for that. There are very specific thyroid surgeons who deal with just, I don't want to say they're general surgeons, they're trained to be general surgeons, but there are some surgeons who just do thyroid, that's their specialty. And they may do that, or the endocrinologist can also do it. Often, another thing to be considering as you're making your referral, most endocrinologists have an ultrasound right in the office and they can look at the thyroid when you send them. So if you're feeling like, gosh, I'm new in practice, I'm not sure what to do, I would like to send, I ordered I got my TSH back, it was low. I ordered my T3, my TPO, my TSI, my ultrasound. And then instead of ordering the ultrasound, you can ask the endocrinologist, just make your referral and ask your endocrinologist to do it. If they need to then do a biopsy or the radioiodine scan, they can do it in a more, a better flow with it, right? So less back and forth for the patient, a quicker process. All right, and this is just
get the labs first, so that he has the labs. Get your,
yes,
TSO,
yeah,
okay.
and the labs are you'll have return in 24 hours. So
yeah,
the labs will go quickly, but if any of them are abnormal, I'm going to want to send my patient to the endocrinologist. Mm-hmm. If they're not abnormal, I might just do the ultrasound and make sure everything is okay, and then monitor the TSH and the T3 and make sure everything is all right. But it doesn't hurt to have that consult. I happen to have endocrinology very accessible to me. When I lived in Colorado, I did not. And so I treated hyperthyroidism. I treated everything because I didn't really have endocrinology available to me. However, now that I do, I have no interest in playing with these medications because they're kind of crazy to me. All right. All right. So if you have the radio iodine update scan, you're gonna see if it's high, you're gonna get it's probably going to be Graves' disease or a multinodular goiter or toxic nodule, or with a low level, it's going to be thyroiditis, excess thyroid dose or amiodarone, which would cause excess levothyroxine. All right. So is it on here? Can anybody name a drug that you would use to treat this?
Are you talking about treating hyperthyroid?
Yes.
I mean, iodides, wasn't it? Like it was mentioned, iodides.
Yeah, not as commonly, but radioiodine, it can is a way to kind of stop or slow down the function. You cannot do it in pregnancy, and it's safe and effective, but I don't know, I guess I see more people treated with pills, I feel like, but I'm not the endocrinologist. If it's ridiculous, causing big problems, then you can have the thyroid removed. That is less likely, but you can also have secondary issues from that related to the vocal cords or the parathyroid glands, which we'll get to. And then the antithyroid drugs, I see a fair amount. But again, maybe that's because I'm in primary care and I'm not doing surgery and I'm not giving radioiodine. All right, so we're going to talk about that. Methimazole is the one that is more commonly used. It has been found to be a little bit more effective. It is also, oh goodness, I thought it was once a day. It might be twice a day. Does anybody want to look that up for me? How often you give methimazole? Anyway, this inhibits the thyroid hormone synthesis because it blocks the oxidation of iodine. So it acts directly on that iodine. So if you remember that little picture, the iodine does not go in, and so you can't make the T4. And then you therefore can't get T3. You can get a granulocytosis with this, and so you do want to monitor if someone is pregnant. Pregnancy does weird things to your thyroid. So if someone is pregnant or newly postpartum, meaning within the first year, they might have thyroid issues. You should watch closely. I actually had a woman very recently she was my prenatal patient, but I think as she was pregnant, she was saying, okay, so I just want to let you know that my mom and my grandma both, after they had their babies, they had a thyroid issue and they had to start taking medicine. And sure enough, she had her baby and her thyroid was an issue, and she had to start taking medicine. So that is not uncommon. And it is not uncommon that it is hereditary like that it was passed down. That is often the case. Thyroid issues are often also seen more commonly with people who have type 1 diabetes, autoimmune diseases, but type 1 diabetes is the most common. So methimazole, as much as I think it's a great medicine, it's pregnancy category D, and so you don't want to be using it until the second or third trimester is okay. PTU is our other option. This inhibits the thyroid hormone synthesis by blocking the oxidation of iodine. It can also cause a granulocytosis, and it's usually used in the first trimester. So thyroid hormone crosses it affects the baby. That helps the baby's growth or impacts the baby's growth. And so you can't leave it untreated. You need to be treating it. So even though this is not good to be taking during pregnancy, it's kind of the lesser of two evils. It makes me think of when someone smokes and you give them a nicotine patch when they're pregnant. Like they say, well, is this safe in pregnancy? And I say, no, but it's better than smoking. It's not safe, but it's better than the alternative. So There's the iodides. I see this not used very often. It inhibits the organification of the thyroid, blocks the thyroid hormone release, and inhibits the peripheral conversion of T4 to T3, and might actually decrease the thyroid gland size. It's contraindicated completely in pregnancy. People can have allergic reactions to it, so be careful, and it can cause a metallic taste in the mouth. Again, I don't see this used as often. And then beta blockers are not going to do anything for the thyroid gland, but they're going to make somebody feel a whole heck of a lot better. So before the medication, just like anything else with the thyroid, it takes weeks to take effect, right? And so because of that, you have somebody who in the meantime has feeling like their chest is going to beat out of their, or their heart is going to beat out of their chest, or they might have an arrhythmia. And so by giving a beta blocker, it can be very helpful in calming that down, helping with their anxiety. And I do want to say, like, don't hesitate when you see somebody. I saw a new patient the other day who he was a tall, thin guy. Men have kind of the larger Adam's apple, right, than women. And so he's tall and he was skinny and it looked kind of big. And I was like, has anybody ever looked at that? He said, no. I'm like, I feel like we should look at that, right? He had 2 tiny nodules. It wasn't a big deal, but don't hesitate to, if you think it doesn't look right, then it doesn't look right. All right. All right, so I'm sorry, I had somebody look this up, but methimazole is given once a day, and PTU is 3 times a day, which is why we use methimazole a whole lot more often than PTU. Here's some side effects. We talked about the first trimester of pregnancy. PTU is really what one to choose, but they are both safe in lactation. So again, you want to be checking the thyroid during pregnancy if there's any anomalies, and if somebody already has hypothyroidism, at the onset of pregnancy, you want to be following that as well, but we'll get there. It can cause neutropenia, like we talked about. And some of this treatment is pretty long-term, and so you do want to be monitoring these things intermittently. If somebody gets through the first 90 days, they typically won't have issues, but it can, as you know, side effects can come on at any point. Pay attention with these folks. Fever, sore throat, that can happen in the first couple weeks, and make sure you're getting a white blood count and make sure that it's not neutropenia. Okay. And obviously sepsis is a potential issue. We talked about pregnancy being and the most commonly changes in the first trimester and the year after delivery. It can be transient because of hyperemesis or because of a high HCG level. It can, and it's usually related to Graves' disease. And it's 2 in 1,000 pregnancies. So this is like a 0.2% prevalence. So not very high, but it is certainly present. All right, we talked about PTU, safer until 16 weeks. And for pediatrics, they are most likely to get autoimmune Graves, especially if there's a family history of it. It's more likely. They could also have thyroiditis, which it's transient, right? So recheck them again in 4 to 6 weeks or maybe 8 weeks. Also, as a growing child, think about that pituitary gland and make sure that it's not a medication they're taking or it's not pituitary gland related. So you would probably want to do an MRI of the brain to rule that out. And kids can be treated with methimazole, radioactive iodine, or surgery as well. With a child, they might actually pick surgery or radioactive iodine just to get it dealt with, so that it doesn't return later in life. One of the issues with methimazole and PTU is it can come back after treatment. So I think I have it in here somewhere. Yeah, the treatment for where is it? Methimazole, a minimum of 18 months, but I saw some studies that recommended up to 10 years of methimazole because the hyperthyroidism can return. It's more commonly about 24 months. PTU, I didn't find the same data on. I'm not sure why, maybe because it's not as well tolerated. Anyway, so, oh, so weird. I don't know if we, okay, we have to finish that one. So I want to go through, and I would just want to kind of go through. So I don't know if you guys can see everyone on your thing. I guess, I don't know, I just want answers about what you think this could be. So if you have someone come in with just a tremor, what is your differential diagnosis going to be?
Like alcohol withdrawal.
Okay, that's one, alcohol withdrawal.
I mean,
Parkinson's.
hyperthyroidism.
I'm sorry,
Hyperthyroidism.
hyperthyroidism. Thank you. Parkinson's was another.
Can they be hypoglycemic too?
Yeah.
Yeah.
Medication can cause
Albuterol or something might.
Medication. I'm sorry, what'd you say, Becky?
Albuterol sometimes can make people come
Albuterol
shaky.
can cause that. Yep.
Caffeine.
Caffeine.
Drugs.
Drugs. Yeah.
Yes. Even lack of sleep, like when people are really out of it. I'm sorry, what'd you say?
No, that's what I was saying, but I was muted.
Oh, I heard you in my head. Yeah, sleep deprivation, like if somebody's really, really just not getting enough sleep for a prolonged period. Okay, so huge list of differential diagnoses there. What about with anxiety? What are your differential diagnoses with anxiety?
Anxiety, like as a
Yeah,
new
drugs
diagnosis.
as well.
Yeah, anxiety is a diagnosis. And okay, let's talk about this. What is more common, anxiety or hypothyroid or hyperthyroidism?
Anxiety.
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 More common. So when someone comes in and says, I'm anxious, I feel like my heart is beating really fast, like, I can't sleep at night, I feel anxious all the time.
Just review their social history.
Right. Well, and that's what, I don't know, in our office, we use the GAD and PHQ, which I guess you guys will get into in your psych class. But that's the General Anxiety Disorder Questionnaire and the PHQ Patient Health Questionnaire, which is a depression screen. It's PHQ 9. It's just a 9 question. So they're both pretty short. But yeah, assessing those to determine, and when you get those, you really want to read what they are, because you want to determine if somebody is happy and they feel like things are going well, but you know what, they might be anxious because their heart is going fast, right?
Yeah.
And so
Okay,
it
yeah.
really is hard to tell. If they come in with an arrhythmia, that makes me think a lot about age, right? Like,
Mhm.
are we 60? Are they 20? So why would it, go ahead, Nee.
I was gonna say, alcohol, substance use also cause some of these arrhythmias.
Yeah, electrolyte abnormalities. What else would cause like an arrhythmia in a 25 or 30-year-old?
Drugs again.
Drugs. What else? Something more psychosocial again.
Panic attack. Or
I didn't
anxiety?
hear you. What?
Panic attack or anxiety.
Stress. So yes, maybe not a panic attack per se, but just excess stress. So think about a graduate student who's about to defend their PhD or is behind the gun because they, are not getting, their research project isn't going forward the way it should, or because, or even, an undergrad student who is anxious about class, they're not doing well, or whatever that could cause, that's enough to cause tachycardia. And then I don't think I have to go into somebody who's older. Any kind of cardiovascular disease can cause an electrical dysfunction in the heart, and so that can just happen with age. How about
Also congenital. I feel like sometimes people come in and they have these congenital issue that wasn't bad, and then they get to a certain age where your heart can't compensate anymore, so you start to have these arrhythmias.
You bring up something really good, Nee, is that when you're looking at these things, don't forget about like the basic something that was congenital that you think that, you know, like it's never bothered them before, but it maybe it's been going on. I do catch congenital issues later in life sometimes that just never got caught before. How about skin thickening? What does that make you think of?
Diabetes.
Diabetes? Why diabetes?
That skin conditions where, you know, in the crevices, like your
Oh, the darkening of the skin.
Yeah.
Yeah. Okay. Acanthosis.
Campus nigrans.
I can't pronounce it.
Acanthosis. It's okay. I clearly have my own issues with ophthalmic exophthalmia. Anyway, what else could cause skin thickening?
Some kind of skin cancer, maybe.
Potentially, yeah.
I mean, overuse. Like, I know, like, certainly my like people I know, like, if they keep like they do, you know, certain work, like labor work, and they keep rubbing on that same area over time, that skin's area gets.
Absolutely, yeah. What are some other common skin issues that cause thickening?
Eczema or psoriasis?
Absolutely. Thank you, Laura. That's exactly what I was thinking. Yeah, so all kinds of things. And then maybe not thickening per se, but discoloration that you might see with thyroid hyperthyroidism could be from venous stasis. Yeah, there's all kinds of things. Oily skin. What else could cause that?
Sometimes just natural for some people.
It is. Sometimes it's just natural. And women, particularly as they go through their menstrual cycle, they get oily skin and then they get dry skin and oily skin, and it changes, it vacillates quite a bit. And there seem to be periods of time in people's lives that for a while they tend to have more oily skin, and then for a while they tend to have drier skin. And so it's harder to determine. Okay, here's a big one. I want you to like all get out your pen and paper and write down all the differentials you can think about for fatigue. There's a gazillion of them. And I'm gonna eat a little bit of my lunch while you're talking.
Anemia.
Anemia, good.
Depression.
Mm-hmm.
Low vitamin D.
Mm-hmm.
Cancer.
Who haven't I heard from?
Not
Children.
sleeping well at night.
I was gonna say insomnia. Oh,
Yeah.
that.
Okay, so along those same lines, what else? There's two more things that go along with that.
Heart failure.
Okay, more than two. Good.
I think of diabetes because, like, if you're not able to use the energy that your body has because it's locked up, you're going to be a lot more fatigued.
That's right. Yes, especially after meals.
Yeah.
Hypothyroidism.
Yeah.
Yes.
I'm sorry.
I think he said
Depression
hypothyroid.
I heard hypothyroidism. I thought there was something after that.
and depression. Like if you're right, aren't you get tired from?
Yeah. What else?
I mean, if you have like disorder of your circadian rhythm,
Mm-hmm.
like some pituitary problems that could cause.
It could. Tell me some other
Dehydration. Like if you're dehydrated, you get tired too.
potentially. What are some other sleep issues that could cause fatigue?
Yeah.
Sleep apnea.
Sleep apnea.
Yeah.
And okay, so when they do the test for sleep apnea, what else do they check?
There's something where people feel very sleepy during the daytime. But what is it?
Exogenous.
Narcolepsy. Yeah.
Yeah.
What's the other thing they check for during a sleep test?
How many times you stop and start breathing?
Obstruction. I can't think of it right now.
Well, apnea
Snoring.
is one of them, but what is the other thing they put the little, has anybody ever had a sleep study?
No.
I had
I
one
mean,
just the
I
other
saw
day.
one done in the hospital, but I think they did I mean, we put on the O2 sat,
Yeah.
Uh-huh.
and then we do the pattern. It looks like that's what they did. They just kind of like monitored the pattern.
Okay.
Oh,
They
is it
did,
like
they hook up all kinds of things to like your arms and your legs and your brain and not your brain, but like your scalp.
Like periodic limb
Brain
movement.
activity.
Yes. Who said periodic limb movement?
Me,
Oh,
Lindsay.
Oh,
Lindsay.
Lindsay, thank you. That's what I was getting at. Yeah, if they're not sleeping because their legs are moving all night, then they're not sleeping well. So fatigue can come from so many things. It can come from stress. It can, I mean, like, and then somebody mentioned anemia, and vitamin D, low vitamin D, but low vitamin B12 can also cause fatigue. Arrhythmias can cause fatigue.
what
COPD.
about beta blockers?
Asthma. What's that?
Beta blockers.
Beta blockers, medication side effects, and all kinds of like, and oh my goodness, I had some woman, I feel horrible. She has been on Lyrica. It's not been a high dose, but she has been falling and she's been complaining about not being able to think straight and not being able to finish tasks at home. And she has chronic pain to start with. So to have pain and not be able to finish any tasks in addition to that, because she can't focus. She couldn't pay attention to a conversation. She got off Lyrica. She got off amitriptyline or nortriptyline, one of those, and omeprazole, which the latter was probably not contributing, but she's like a new person. Her balance is better. Her energy is better. Her mental capacity has resumed normal. Like she's like a normal person again. And she was like on, I want to say a low dose of Lyrica, like 25 3 times a day or 50 3 times a day. So, you know, you have medication side effects are definitely a real thing that could be causing the fatigue. And COPD, asthma can cause fatigue. Those are not primary symptoms that people tend to complain about, but they certainly can happen. When your body's not getting enough oxygen, then that can be the case. All right. And then insomnia, it's kind of similar to fatigue, right? Like, you know, stress and restless leg. There's all kinds of things that cause insomnia. Exophthalmia is one of the things that has very few things in its differential diagnosis. And so if you're seeing exophthalmia, it most likely is hyperthyroidism. All right. And then we already talked about monitoring when you're on those, the methimazole or the PTU. The first 3 months are the most common. You really want to watch for that sore throat, for that neutropenia. And we talked about the long treatment period of time. We're going to go to we're going to go to hypothyroidism. I'm going to try to go a little faster. So we talked about kind of our symptoms. I want you to just take note of myxedema coma. We're going to talk about it a little bit more in a bit. A lot of people actually die from myxedema coma. It is more common in females. Thyroid issues in general are more common in females. Oops. Yeah, I think that's all. You guys can look at that. Oh, this didn't turn out as pretty as I was hoping. So these are the symptoms. I think we've gone over most of these. Sore muscles and joints are something that we didn't mention before. Malaise, memory issues, depression. The depression really comes from not being motivated a lot of the time. It could be primary, meaning coming from the thyroid directly with Hashimoto's thyroiditis, which is an autoimmune issue. It could be an iodine deficiency, like we talked about earlier. It could be because of prior radiation, either external or the radioiodine. It could be a thyroidectomy. People are amazing that they should be on thyroid medicine and they have decided to stop for, I don't know why. I can't tell you how many people tell me that. I feel like everybody wants a drug that's going to make them feel better. And that's really, for people who have hypothyroidism, that's levothyroxine. And I don't know why you would quit it, but people do. There's also, we talked about the postpartum thyroiditis and medications that can cause hypothyroidism. There's also, and what medications? Name 2 medications that can cause hypothyroidism.
Maybe methimazole and BTU.
That was totally cheating. Beta blockers are one. There's another one. I want to say it's amiodarone, but I could be wrong. Anyway, you could also be from a pituitary adenoma. So again, when you're getting these abnormals, you want to make sure that you're thinking beyond just the thyroid gland. You want to think about how thyroid hormone is made. Yep, I was not totally crazy. Amiodarone was on my list. Is beta blockers are not on my list. I'm pretty sure that beta blockers can decrease the function, the opioid, not opioid, sorry, I just looked at opiates, TSH secretion, but opiates can also. Dopamine, all right. Lithium, pay attention to lithium. Lithium's like a wonder drug, and at the same time, it is, has all kinds of crazy side effects. Lithium can actually burn out someone's thyroid, and they can be on thyroid medication the rest of their life. Obviously, we want to normalize the TSH. Naturopaths treat with Armour thyroid. I tend not to. It's desiccated thyroid, and I'm not. It is like a direct. It's a weird combination. It's not as consistent as what you're going to get with getting levothyroxine. By the way, just a note that insurance will pay for tablets of levothyroxine, but it will not pay for capsules of levothyroxine. So you just want to take a note of that. And then you can also give Cytomel, which is a T3. So clearly, if you give straight T3, it's going to be biologically active immediately, but it also has a short half-life. And then there's also Thyrolar. I've not seen that used before, so I'm not as familiar, and I would leave that for endocrine to give. I also won't give T3. I just don't feel comfortable with it. It's not something that I've done before. All right, mixed edema. Okay, have you guys heard my story about my patient? I haven't seen you guys in a while.
I think so.
I think so. No.
Oh, I don't know.
I didn't know she had a myxedema. She had a myxedema coma. They diagnosed her in the ICU. So this woman had been coming to me for years, and she would like kind of shuffle in with her walker, and her eyes were kind of always halfway open, and her oxygen level would vacillate. She had COPD, she had severe depression and anxiety and all kinds of psychosocial issues. Her grandchildren were in her custody, but they verbally abused her on a very regular basis. She just couldn't ever really do anything. She had just coarse black hair, that's how she always looked. She was always kind of puffy everywhere, but she was overweight, right? She was pretty obese. Her BMI was probably 40, 43, something like that. And she came in once, and she overdosed on opioids. She told me that she didn't, but she did, because they gave her Narcan in the hospital and it worked. And her O2 sat was like 50 in my office. And so like when coming in like this was her baseline. I mean, not the opioid overdose, but the baseline was this woman who was like, yeah, she would fall asleep while you were talking to her. This was ongoing. Like somebody, I sent her to one of the nurses to work with, and she was like, I don't think that she's really engaged. She was falling asleep while I was talking to her. I'm like, oh no, she just can't stay awake. Like that's not because she's not interested. So she, this is not the right thing to do necessarily, but I couldn't get her to go to the emergency department for anything. And so she had pneumonia, and she had pretty bad COPD and smoked, and she had pretty severe, I think she probably had asthma and severe allergies on top of it. And she had pneumonia, and I knew she had pneumonia, and I wouldn't treat it because I wanted her to go to the emergency department to get treatment. I mean, like her oxygen level was like 90 or 88 or something like that. Like she was sick. She needed to go in, and she was like, no, I can't. I have to. I'm like, okay, you have to go tomorrow. And she's like, you know, whatever. And so she went, and she had respiratory arrest in the ED. And was given a trach, which she had for the rest of her life. While she was there, she was diagnosed with a myxedema coma. And she was ataxic, but she had what's it called? Her cerebellar tonsils were large. That has a name, but I can't remember what it is. Anyway, sorry, it's kind of on the top of my head, but I can't spit it out. So what I'm saying is, here's this woman that I'd known for so long, and I did not know. I was also, I don't want to say questioning. It's interesting to me that her TSH was like 64. And the only reason I believe that it was myxedema is because after they treated her with her thyroid medication, she was normal. Like, I mean, she wasn't normal, but she was a whole new person. So I just, again, I see this person, but I see that, like, you know, droopy and head, you know, eyes drooping and kind of blah, you know, just no energy. But this woman was ataxic. She would fall into her house all the time. It was awful. Anyway, we're going to treat these people with levothyroxine more often than not. Please, when someone takes levothyroxine, make sure it is not with any of these supplements or medications, including sertraline was on there. I recommend sometimes that people set your alarm for 5, take your medicine, go back to sleep, or whatever, you know, don't get up, or some people will, I think it's about an hour, you have to wait, half hour. So I say, get up, you can take it when you get up, and then, you know, take your shower, brush your teeth, get ready, and then you can eat. If you see the absorption rate levels with fasting, it's 80%. If it's non-fasting, it's closer to 65. So it's a pretty significant difference of the amount of medication that they're getting. When you're giving in pregnancy, you want to initiate a little bit different than you would otherwise, just with great care. Same thing with the elderly. You want to take great care with that. All right, dose adjustments. I know that Dr. Bowman really said 6 to 8 weeks. I really often stick with my 4 weeks, but you know, just keep an eye on it, I think, is the more important thing. And then you don't want to adjust by more than 25 micrograms. And I believe you can often not adjust by any less than 25 micrograms. That's how the dosages tend to go. Sometimes you can do 12, like there's a 100 and a 112 and a 125. So there's sometimes an in-between one, but don't go more than the 25 micrograms. And then warfarin and digoxin can interrupt the metabolism of levothyroxine, so something to consider. So if somebody's gonna have issues with thyroid, most often happens in the first trimester. When I have a patient who has established hypothyroidism in pregnancy, I usually just check them about every 2 months, just to make sure that their thyroid isn't changing. The Armour thyroid does not cross the placenta, and as we were discussing, the baby needs that thyroid too. So you want to make sure you're using the levothyroxine. When pediatrics get hypothyroidism, it is also most likely autoimmune. Hashimoto's is the most common type. It could be thyroiditis as well, though. So when you have somebody who has a low thyroid, I had another 15-year-old who, much more recent though, who had hypothyroidism. And I was like, really? Well, I'm not sure about this. And so we rechecked it in about 6 weeks, and she still had the same level. And so we started her a medication, and there's not really a whole lot more workup that needs to be done. But if you feel more comfortable, then you want to refer to the endocrinologist until you feel solidly comfortable with your decision. That can come from your colleagues or from Up to Date, but you really want to feel solid before you're not referring, particularly pregnancy and pediatrics, out. And then Older children and adolescents, you can check every 3 to 12 months. Younger children, you want to check more often. And I wouldn't, the adolescents don't bother me, I wouldn't want to treat a child. I wouldn't want to be the primary provider of the levothyroxine to a younger child. I want somebody else to monitor them more closely because it has so much to do with their metabolism and their growth. All right. Obviously, the elderly are more challenging. They're more susceptible to AFib and osteoporosis. And so you have to be particularly careful with that. They say they recommend the American Thyroid Association, I think says that you can leave them a little on the higher end, but really evaluate your patient and see how they feel. If you have somebody who's, I think it's, 75 or 80-year-old who like goes to the gym and lifts weights. She's quite spry. I'm not going to put her if she's feeling tired, I'm going to put her at a lower level. So evaluate your patient, treat your patient. Don't just follow guidelines. All right. I'm going to skip this differential diagnosis because I don't want to take up too much time. I want to make sure we get through our material today. We can come back to it, but we already talked about fatigue and sleep. And little interest in activities gives its own thing. Hard to focus. There's all kinds of things for that. And the cold, there's a few things for that as well. But this might be a little bit easier to diagnose than hyperthyroidism. Just quick with nodules, lots and lots and lots of people have nodules. Lots and lots of people have nodules that don't mean anything. So that guy he was the tall, skinny guy who looked like he had a goiter. He had a couple nodules, they were benign. Well, I don't know that they were benign. They were under 1 centimeter. If they're under 1 centimeter, then you can ignore them or you can monitor in 1 year and recheck. If it's over 1 centimeter, it does need a biopsy. So common thyroid nodules are common. Cancer is found in 5 to 10% of nodules. But it does happen. A couple of years ago, had like a 30-year-old who had a thyroid cancer. And she interestingly worked in radiology. And so my guess is that she'd been exposed to enough radiation that she got thyroid cancer. Oops. All right. So we talked about the adenoma, which is just excessive tissue growth of the thyroid. Cysts it could be malignant or benign, but they're more likely to be benign. Inflammation is what Hashimoto's is, just chronic inflammation of the thyroid. We talked about iodine deficiency, and then a little bit about the benign nodules, but they're not always benign. So, all right, and then they obviously can be cancerous, and that's why we want to refer and make sure we get that biopsy if they're 1 centimeter more. So I think the take homes from this, I would say, is know your methimazole, know your levothyroxine, your diagnostics, how to get your TSH, T3, T4, TPO, TSI, ultrasound, and biopsy if on your ultrasound it's greater than 1 centimeter. If I had to put it all in one slide, that's what I would say. Okay, I'm gonna go through that. And this is very similar from what I just said. I just thought this is a nice flow sheet. That's some pictures. You can compare them when Dr. Schwink starts to teach you some ultrasound stuff. I don't know if you will do thyroids, but they're I don't want to say they're easier to do, but they're one of the things they do in the office. And so it makes me think they're a little easier to do. Fine needle aspiration is what they do if it's larger, and it's not always diagnostic, but it can be very close, and sometimes it needs surgery. All right. So pregnancy, making sure you're identifying and treating thyroid issues in pregnancy is important because you don't want a placental abruption. You don't want a miscarriage. You don't want hypertension disorders, growth restriction. So that's important stuff. And let's see, talked about most of that already. Okay. Screening pregnant women, postpartum, we already talked about. I'm going to skip that. I'm going to skip this case study today. Here are questions that you should just like when we were going over the labs last week and I said you should do those on your own, I encourage you to actually do them. You will be appreciative if you go through each of these things and you look them up. This is specifically about the case study, but with the labs, really looking that information up, I think is pertinent. And then knowing these things here, and then we're going to talk about the parathyroid glands really quickly. Hypoparathyroidism, the parathyroid glands are what control the level of calcium in the blood. So if there's too much calcium, it's going to go into the bones. If there's too little calcium, it's going to take from the bones. When someone has a thyroidectomy, those guys are little, like a grain of rice, 4 little grains of rice in there. So if you do a thyroidectomy, the likelihood you're going to lose them is very high. Same thing with neck radiation. They're not separated. You can't separate them really from the thyroid gland. And so you're going to lose function of your parathyroid hormones. It could also be because of like primary autoimmune disease with the parathyroid hormones themselves, or it could be hereditary, that it runs in the family. Low magnesium can also cause it, so make sure you're checking your magnesium. That is not something on your CMP, so it's something you have to check separately. So this is particularly interesting to me because I had I don't know, 28-year-old, 32-year-old who had hyperthyroidism on top of severe anxiety and depression and PTSD, but with a recent rape. And so she had not quite recovered from that. And so she had hyperthyroidism, but she was clearly like a mess from everything, right? Has 2 kids, single mom, worked. So really difficult. So because it was so bad for her and she felt like she couldn't swallow, kind of all kinds of stuff going on. So we referred her to the surgeon. She took out her thyroid and she had not great follow-up, but she would come in and her fingertips and her toes and her lips would be tingling and she would get cramps, lots of twitching in her arms and her hands, sometimes twitching in her face. She was always fatigued, so I don't really know how much that played a part in it. I don't know about the, hair loss, dry, coarse skin, brittle nails. She didn't have seizures, thankfully. And malformed teeth really only happen in children who have this issue. And she did not have renal issues. I don't know that she had any arrhythmias, didn't have syncope, didn't have arrhythmias when I saw her. So, but it was really interesting to me. And she was on, I think she was taking 2 Tums, like the Tums extra strength or whatever, 3 times a day, 4 times a day, plus the vitamin D. And she couldn't get rid of these symptoms. And the only thing that would get rid of her symptoms was calcitonin directly, which was not something that I would typically prescribe. But she wasn't getting to the endocrinologist. So I gave her some calcitonin for a while. And interestingly, it's been a year and she's fine now. She's not on the calcitonin anymore. She's stabilized as long as she takes her calcium consistently, which she does a fair job at, but not great. And then hyperparathyroidism going the other direction. So this would be your body taking calcium from the bone and putting it into the blood because of an excess of parathyroid hormone. This can be because of the enlargement of the parathyroid glands or adenoma or other process in the body. So severe calcium or vitamin D deficiency can cause that. Tell me someone why, or what is the correct dose of vitamin D and for someone in the Pacific Northwest? It can be a range.
Yeah, I think
1,000
it
to
depends.
5,000.
5,000 units.
Yeah.
I usually say 1,000 to 5,000. I don't say 10,000. I think that that's too high. Very rarely do people have vitamin D excess and toxicity, but it does happen. So it's a big deal. The other thing is kidney failure. And I don't know how familiar you are with kidney failure, but the kidneys take vitamin D and changes it into a form that the body can use. And so if you have kidney failure, and usually like late stage 3, stage 4, obviously stage 5, you're going to get poor conversion of the vitamin D, and so you'll get hyperparathyroidism with that. You can give vitamin D supplement with that, and that's usually 5,000 units per week. But it's something like when you're doing your chronic kidney labs, you should have your in your cheat sheet book, whatever you have. I know everybody's electronic these days, but sometimes a book is nice to have. That is, you want to know your chronic kidney disease labs, because calcium and parathyroidism or parathyroid hormone are in there of things that you need to be checking. All right, so osteoporosis, clearly, potentially kidney stones because you're having excess calcium in the blood, excess urination, abdominal pain, tiring, weakness, forgetfulness. So do you feel like it could be hypothyroidism as well, or it could be more things than one. Bone and joint pain, that is an interesting one. People describe bone pain and you don't really know what they're talking about sometimes, but reason to check the parathyroid hormone, which is not something that gets checked very often otherwise. All right, so we want to monitor the PTH and the calcium level, and potentially take the parathyroid glands out. All right, and then we're going to move on to the next one. Oh, hold on.